We're here at Avenues to discuss male fertility and specifically how AI is going to be changing the game for men like myself who required fertility treatment as a result of male factor fertility issues. So yeah, I'm really excited to get into it. First of all, we'll go through some introductions. So myself quickly, I'm Shaun Greenaway. I'm a male fertility advocate and co-founder of Nexus Fertility, which is a support platform for men who are going through any fertility struggles at any phase, and even on the other side as well, because we're always living with it, of course. And so without further ado, we'll get into it. So on to my right here, we have Halil. Hello, Halil.
Yeah, hi. Hello, everyone. Welcome.
So if you can just introduce yourself.
Oh, yes. I thought we were just going to go around. Anyway, my name is Halil Ruso. I am an embryologist. I'm a senior clinical embryologist here at Avenues, responsible for directing the innovation aspects of the lab, of course, on top of my daily routines. So I'm an enthusiastic embryologist with a keen eye to the introduction of new things and quite fond of challenges, let's say. So I like those difficult ones where, you know, out of the box, thinking is necessary. So I take pride as a clinic and as a person as well in thinking on in those aspects when it comes to male infertility.
Amazing, thank you. Good evening, Jonathan.
Good evening, and it's very nice to be here. I'm Jonathan Ramsay. I'm a urologist, so I used to deal with all matters urological from the top of the kidney to the end of the penis. And when I was training, one of my trainers said to me, when you grow up, become a consultant, he said, remember, the penis is a blunt and uninteresting organ, but the testicles are full of mysteries. And so in the last 20 years, I've concentrated on male fertility and particularly the quality of sperm. So Halil and I are bonded over sperm quality.
Thank you. We have Ryan.
Right. I'm definitely not an expert, like everyone to my left seems to be. I'm just a dad. I've got a almost 4-year-old son. His arrival was pretty complex. His mum was super unwell for the best part of a year. And I find myself deep in the journey of male fertility right now. I've actually had some appointments here with some of the guys. And it was a very humbling experience because I think I sort of entered that process feeling not invincible, but I just thought that I was there in a supportive capacity. And then the conversation kind of swung towards me. And I had to go through some testing of different sorts. I'll leave that chat to you. And realised that I wasn't quite as healthy or as manly as I hoped or predicted I would be in that sense. And yeah, so me and Louise are going through a bit of a journey now with IVF ourselves. And if nothing else, from this evening, I will learn a lot from these guys. So yeah, that's me.
Thank you. Yeah, great. Definition there of not thinking as you're as manly as what we want sport.
Right.
Yeah, something to definitely delve into a little bit more.
Sure.
Yeah, I mean, I was diagnosed with azoospermia in 2018, which is 0 sperm, none. And it's like, all blokes are meant to have tens of millions of these things.
Yeah.
And I haven't got one. So it's a journey. It's a journey of self-discovery and really stripping back that ego.
Yeah.
And redefining who I am as a. Which I think is something we'll definitely come on to. And it's that redefining men in the fertility conversation in general, which is what we're doing tonight. And it's a great opportunity with the chaps here to do that. And so, Jonathan, you mentioned that you've been focused on this for 20 years. Why do you think it's taken so long for the conversations like this to start happening?
Well, I think, Shaun, it is a good question, by which I don't mean that I don't know the answer. But part of it is because until very recently, there haven't been any guys like you two who can actually talk about it at all. So it has been hidden, and things that are hidden turn into a problem, and then they make the owners feel worse and even less likely then to talk or share it. And then alongside this, there's the simple biological fact that all of us want children. And if it seems that the only way of doing that is to have some IVF, then off you go traditionally to the IVF unit, and the poor guy gets even more marginalized there because the focus, the attention, not surprisingly, is entirely on the woman and the ovaries. So you start off not wanting to talk about it, and then that gets worse and worse through the process. And even when the process has succeeded, I think there's some scarring here. It never quite goes away. And the way to make things go away or make them better in medicine is to get a diagnosis, to have an explanation, for somebody to take some care and interest in regarding you, me, or us, the man, as potentially half of the problem, which hasn't traditionally happened. But I think things are changing. The things that you guys are doing, various platforms, and just a bigger awareness. I think people are just beginning to talk about this and to regard not having a baby as a joint problem.
Yeah, absolutely. And when you break it down, and you think, well, now that the conversation is there to say, well, men are 50% of this equation, it seems so commonsensical, of course, because there's two sexes. There's takes two to tango and all that. Why has it taken so long for people to realise that? But like you mentioned, the platform is there now. Conversation is growing, and I know social media can have its flaws, but one thing that it has done is created communities and allow people like myself who needed that community, needed that voice to find it. It wasn't there when I was going through it. When I was diagnosed in 2018, it was a very lonely place. The landscape has changed, and I like to think that that's maybe what has allowed you, Ryan, to open up a bit more early and during the process, because yeah, you know, I have so much respect for that, because I wouldn't have been able to do that at the time. It's like, you know, what was that initial appointment like for you when you were sat there and you were told this news?
Yeah, it just threw me into a bit of a flat spin because it was just so unexpected. I think you know, my motivation, to be honest, is because Louise was so unwell for that first year. She was kind of sort of robbed of the opportunity to become a mum to a newborn, because she was so absent and so removed for so long. So my motivation really at the moment is to give her that opportunity, and if we can have a baby through this avenue, then that would be wonderful. But it did really put me into a flat spin. Yeah, I started to question everything, and for so many years I've tried to live like an athlete, if you like, train, eat well, eat clean, prioritize sleep, supplement, saunas, ice baths, you name it. All the biohacking things I would like really dive into. And then I guess the advice was to sort of turn all those taps off and start addressing some lifestyle factors. Yeah, it was really difficult. Yeah. And to be honest, still is.
Yeah, absolutely.
Still is, yeah.
And Jonathan touched upon that as well. So the scars are there. That's why I mentioned, you know, for the community that we do, is for everyone. I'm myself, like, you know, I have twins now via donor conception and IVF treatment, but I still need that support because it's part of me, and I've learned to live with it. I've learned that trauma is a part of me, and I had a very important lesson in that when, just by a quirk of fate, we went through all the years where friends and family were having children around us, which stung. Of course, there's joy there as well, but then just through absolute quirk of fate, throughout the pregnancy and the first 3 months of our twins being born, we didn't have any announcements. And then there was one And it took me right back to that place. And I was like, oh wow, no, you're supposed to be gone. Like, I've got my kids now, but those scars remain, that trauma remains, and it's it's unfortunately redefined a lot about me, but I try and make that for a positive. And I think with this conversation like this here and the work that you chaps are doing, this will hopefully change that for people coming up behind, and to know that it doesn't change who they are as a person or as a man, which, is a conversation which will keep coming up in the term, because you are so much more than that. And to be present at those appointments, and like you said, after you come out of that spin and are able to take stock and be more present in the appointments, which I'm sure you've seen time and time again, because I've done it, where I've been that passenger, that deer in the headlights in the appointments. Hopefully now we'll start to see men being a bit more engaged, and which I'm sure will make your jobs easier as well.
Well, my lot need to get better at doing this. We need to be having this conversation with a bunch of doctors, because actually what Shaun is describing is not dissimilar from being given a cancer diagnosis. And we are taught as doctors, medical students, how to do that properly. But for most of us, we just haven't got it. We don't get that this is a really dreadful moment. Just a short saying, 0. And then if my lot, the medical profession, can't explain it, it's a bit like telling a young man that there's a cancer diagnosis, but actually you can't do anything about it, and you don't know why it happened. And so that's that. And I think a bit like that diagnosis, what you're describing when you had your twins, it's a bit like being a survivor from a cancer. It never quite goes away, this. And it's a really big deal, which I admit it, we don't get. And when I started 100 years ago, I didn't quite get it either. We were talking about prostate cancer in those days, and I understood how to talk about that. But it wasn't until much later that I got the implication of what you two are saying.
You say about that initial diagnosis, a moment I remember all too well, being told that I have azoospermia, but the person delivering the news on the phone didn't know the words and stumbled over it. And then when I asked what it was, they said, I don't know. So hence me terminating the call, going on to Google and finding out that way, which isn't the best way to find out you've just had a life-changing diagnosis.
No.
But hopefully things will start getting better. But, and that brings us on to where we're at now, and hopefully a more positive future. So that diagnosis that comes from often what is the first element for a man is giving a sample, which is quite daunting in itself. Don't know, how did you find that, Ryan?
Terrifying, mate. Yeah. Absolutely terrifying. Yeah. I've done it here like 3 times. It was just an overshare. But yeah, it's awkward, right? Yeah. It's awkward. They call it the production room in some places, which I find quite amusing. It's not an easy thing, and I think people expect men just to sort of slot in and do the business and be okay with it. But yeah, I don't know how to answer that question. I tried to make it normal in my mind.
Oh, it's impossible to, and like you said, can you just go and give a sample?
Yeah.
No, like the top level bounce will be, oh great, I'll get a free one. But I've had times where I couldn't do it because of that pressure. It was so great walking into that room, knowing that when I came out and the results would be delivered after the waiting, which we'll come on to, that could be yet another life-changing, crushing confirmation of what prevailed each time. It never got any better, unfortunately. So we've talked about that side of the group. For many of us, from the majority of us patients, or if not all, we will never see the other side, looking down the microscope. So how does that look from your side, Halil?
Yeah, so the first line of diagnosing any form of male infertility is, of course, is going to come from semen analysis, sperm requirements, as you say. So there are certain rules that are set by WHO that we need to follow in each semen analysis that we perform. Of course, following these rules. After that, we really obtain the results. We do the counts, We get the motility parameters in, and we get the morphology parameters in by following, of course, abstaining and everything. So even though if we do everything by the book, by the WHO, the diagnostic accuracy or the clinical value of semen analysis is generally on the low side, unfortunately. So other than some critical conditions such as like aspermia, globosospermia, or other defined conditions, anything other than that is going to have a limited diagnostic value in terms of the fertility potential of a man, just by us doing the microscopy work.
Mm.
So nowadays we're getting luckier and luckier in that sense. So we have what we call computer-assisted semen analysis, for example, where we utilize technology to more objectively analyze the semen sample under the microscope, rather than us doing the manual count in a much more subjective manner.
Mm.
Because I can count the same sample twice and come up with two different results. So that's one of the main problems that we have in andrology at the moment. That's why, for example, the authorities are struggling to find quality data to come up with calculations, the cutoff levels of calculations, to say that, look, this is a normal semen that has a certain amount of fertility potential, and this is on the reduced side that has a reduced potential of a semen sample that is going to produce some fertility results. So by using CASA systems that is coupled with AI, we can now objectively analyze how the sperm moves and what that motility may mean when it comes to an IVF sample or an ICSI sample, for example.
Sure.
So there is some advancement there, and we are hoping that it might progress more and change the way we analyze the sperm cells.
Yeah, that sounds like good news.
Yeah.
You know, that takes away that subjectivity, and
Yeah.
I think does that transfer across for morphology as well? That subjectivity.
Yes, it does. It does. So morphology, even though again it's the same rule applies there as well. Even though we have some strict criteria to analyze how the sperm should look or may look, we still don't know per se what a normal sperm is, for example. So how it should function and how it should look like is a matter of subjectivity as well.
Mm. Yeah, and with the AI, hopefully that not only will remove that subjectivity, but
Exactly. So once we remove the subjectivity out of the equation, only then we can come up with other ways and other creative ways of doing causality and reason, to see if we can correlate outcomes with fertilization potentials.
sure. And will that increase the speed up the turnaround time for patients?
Definitely. And on top of that, it will provide more information to the patients as well.
Yeah. And how far away are we from this being common practice?
We are slowly getting there, actually. It's not too far away. We've been practicing with CASA systems, with different ones, and we see that each of them has its own value, has its own pros and cons. Some of them are better in terms of morphology, some of them are better in terms of motility. So we just need to find and bridge that gap in between them to translate it into clinical outcomes.
Great, sounds good. Very positive.
Yeah.
So kind of covered the patient side, the analytics side. How is it from your side, John, from when you're having to deliver that news to patients?
So just as Halil was saying, it's very important, I think, to understand the value or not of the semen analysis, because it is very easy for the owner of that semen analysis on that day to be given the wrong information or confusing information on the basis that it is different, because it varies according to who's looking at it and the day of the week and the week of the month, but also not to be too didactic. Imagine the scene when the man says, "So how's my semen analysis?" So the doctor looks a bit blank and he says, "Well, The man says, well, how many are there? To which the answer is, well, not many. Well, how many? 3 million. How many should there be? 30 million. Well, what else? What else? What about the motility? And what is that? So the doctor says, well, it's 10%. So what should it be? Well, 50%. So that's not very good. And then we get to the morphology, which most men find the most worrying thing, because they think not unreasonably, if my sperm doesn't look normal, well then what about the babies? And then the doctor says, well, I'm afraid it's only 1%. What should it be? 4, 5%? And the bloke goes away almost as badly off as Shaun with no sperm. But we have to understand that this is very variable, and that even those figures do not mean that on a good day with a good quality egg, there may even be a natural conception. So we mustn't put too much store by these numbers, which, as Halil is saying, are variable. They're open to the eye of the person doing the semen analysis, and they vary day to day. It could be that the chap had COVID. Well, that can decimate literally a semen analysis. So not forever, just briefly. So we have to see this in context and be sensitive to all those numbers that we're giving them. And if somebody like Halil educates the robot, because robots, AI needs education, if they have a good teacher, this may be a better way of looking at it, but still it's going to need a human to interpret what it might mean for that couple at the moment.
And how do you think that the increased testing and that objective oversight might help in cases where people are diagnosed with quote unquote unexplained infertility, which I've heard you talk about before?
Absolutely. Well, I'm sure Halil would agree. I mean, everybody in this room would agree that we don't like or want a diagnosis that says unexplained. You know, we don't have unexplained arthritis. We don't really have unexplained skin rashes. Sometimes we might have unexplained headaches, but we'll know what it isn't because we can do an MRI scan. So unexplained is totally unsatisfactory. It's psychologically, emotionally unsatisfactory. And it is our job together to explain the unexplained, to look more closely at those sperm, the DNA in the sperm, more closely at the way they move, and I would suggest the fine-tuning of the genetics of the man who may have a persistently low sperm count or no sperm count. But this involves a lot of testing and at the moment a lot of expense, but I think it will come. Because anything that is expensive now in medicine becomes cheaper as the uptake is there and as the usefulness is there. We can finesse this, I'm sure.
I completely agree. I mean, it is unexplained as we know now.
Yeah.
So in the future, as we understand more things, it will be explainable. But at the moment, with the technology available, we just have that, leap of step into the future, let's say, to become, to being able to explain what is unexplained now, by as you described. I mean, DNA, for example, we're just getting more information and more information. Now it is linked with DNA damage and miscarriage rates are now linked. Previously, it wasn't. Previously, we actually didn't know what it meant. So with these tests like these and with the advancement of science, hopefully everything will be explainable.
So with that science, if you could talk us through some of the new tools. I've got a list here.
Oh yeah.
Listen to me butcher them. Zymot.
Okay.
Spermobile. SID AI selection.
All right.
Neogenics.
Okay. Yeah. Yeah.
I think I did all right there.
Not
Yeah.
maturing there.
So yeah, if you could talk us through
So,
some of those.
yeah. So let's start with design, i.e. So it's actually a generic name. The technology is called microfluidic sperm sorting devices. So during coitus, during natural ways of fertilization, let's say, a man deposits around 400 million, depending on the semen, of course, is going to be between 200 to 400 million sperm being deposited into the vagina. So when we pass the first obstacle, which is the cervix, into the cavity, that number is going to be reduced to 150,000. So a 1,000-fold reduction almost. So the next stage is going to be the tubes where the fertilization is going to happen. The beginning of the tube towards the cavity, the numbers are going to be expressed in a couple of hundreds. So when we go where the fertilization happens, further along inside the tubes, that number is going to be translating into 60, 50 maybe. That's what the research is saying to us. And out of that 50, 60, only one is going to penetrate the egg vestments and fertilize the egg. So if you think about the filtration process that is happening inside the female reproductive tract, we know that actually the boss who chooses the sperm is basically the female. So we try to replicate those processes in the lab as much as we can. So we try to filter out all the dead sperm, all the not mobile sperm, all the sperm with abnormal shapes and everything. And we try to have a population with reduced DNA damage, with normal looking sperm, and that is showing also very high levels of motility. So microfluidic sperm sorting device, i.e. the Zymop as a generic name, that's one of those devices that we use that involves a filtration process that separates the semen, which is actually not really good environment for the sperm, and then it allows the passage of the good ones, in some say, into the final population that we like to work with. So after that filtration process, there comes the SIT, as you say. So SIT is basically an AI platform that in real time analyzes the sperm's movement, just like a CASA machine does, but it does that in real time rather than from a video recording. So once it does that in real time, it is going to give us categories of sperm based on that particular sample. So that's going to be uniquely ranked based on the sample's availability of certain sperm parameters. And it's going to give us, okay, this is an A1, grade A1, so you can choose that one for injection. This is one of the best ones in this cohort of sperm. So we can do, again, objectively sperm select based on motility parameters with the help of this AI, rather than subjectively selecting. Me, for example, I like sperm to show that sort of, X sort of parameters for my selection case, let's say. But my colleague might be selecting a different one. So we try to unify those and then try to objectively select sperm cells for injection. So motility, as you may understand now, is one of the key parameters that we use for our sperm selection processes. So motility in terms of passing through the filter, and then motility in terms of making it to the last single sperm so that we select it. So sometimes motility might be on the low side or doesn't exist in some samples. So we need to differentiate between a viable sperm and a not mobile sperm. Sometimes they just need that kick in terms of, kick in terms of caffeine shots so that you wake up. So spermobil it's a chemical compound that we use. It's a generic name again. It's actually a variation of caffeine. It's called theophylline. So that we put it in there, it makes the sperm move more faster, maybe, or wake up the sleepy ones so that they can start moving so that we can select the most viable sperm in the cohort if motility is not readily available. We like to use it in testicular samples, for example, where we most often find immotile sperm cells. So in those cases, we like to use spermobil for our selection purposes. And the last one was the neogenics one,
Yes.
I believe, yeah?
Yes.
So neogenics one is something that we during theses that we like to use with Jonathan, of course. So sperm search during a thesis cycle is going to be, rhetorically speaking, is like searching for a needle in a haystack. Just think that needle is basically a couple of micrometers in diameter, basically. So we got a lot of cells coming from testicular biopsies. There will be Sertoli cells, other somatic cells, and other sperm series cells as well that will be present in the testes, hopefully. So they kind of block our way and carries away our attention from finding the sperm cells quite accurately, as I say. So and also when I'm looking down the microscope, let's think that this is my rib, and my attention span generally is isolated to around this big, some area that is this big. So the way we work around is that we just move in a systematic way where our attention span is, and then screen the whole thing to search for presence or non-presence of sperm cells. So as you can imagine, this is going to be a lengthy process. It's going to be a time-consuming process, which is something we don't like, because once we have the sperm cells, we just want to inject them into eggs straight away, because they are fragile cells. We don't want to delay the injection procedures, yeah, or we don't want to delay the freezing procedures for future use. So neogenics is an AI system that we use that detects sperm cells quite rapidly, actually, under the microscope. So on top of our expertise and our attention as humans, as embryologists, we have the third eye watching us at the same time. It is going to increase our accuracy, and is going to increase our speed when it comes to identifying sperm cells in a nasospermic case, or in a sample with very, very, very low concentration of sperm cells. So these are the technologies that we have.
Thank you so much. And when my wife asks how this event has gone, I'll definitely be leaving out the bit that you said the female is the boss.
Oh.
We all know it. Jonathan, if you could touch upon DNA fragmentation, please.
So it's one of my obsessions. So as Halil has been describing, everything that he's been describing is about paying attention to every detail that you can see with a sperm, that you can provoke by giving it some drugs, that you can image analyze by AI techniques, so that the human's attention span doesn't become so important. But once we've chosen, we think we've chosen the best looking sperm and we've given it some drugs and it's moving, then what about what it is carrying? Is its appearance enough to conclude that its internal workings, particularly its DNA, is sufficiently robust and normal to cause an embryo that will implant and won't miscarry and will result in a live birth? And that's where the DNA quality of the sperm, which we've been able to measure really for 25 or 30 years, may be important. Now, I use the word maybe because there's been huge debate about DNA fragmentation. And many people have been reluctant to look at this, particularly, it has to be said, gynecologists, because they can't quite see the point. And this is because our thinking about DNA fragmentation has not been sufficiently refined, because there are different types of fragmentation, some of which can be improved by lifestyle, by treating a varicocele, by all the stuff that goes with fitness, not being overweight, and the DNA quality of the sperm, just like the DNA quality of our skin, our bones, or our other organs, can be improved. And then this couple might have a natural conception or a better outcome. But there are more serious forms of DNA damage within the sperm, which may not at the present time be visible, which may result in a miscarriage, may result in not enough embryos created at IVF, or those embryos, and even when they've been biopsied and declared normal, from not surviving to a live birth. And this form of DNA damage, the double strand breakage, has really only been a test commercially available for the last year. So we're feeling our way with it. But this may be a much better test of where a man is on the spectrum. Is he the sort of man who can improve his situation, or is he the sort of man who must rely, together with his partner, on advanced sperm selection? Now, of course, the holy grail will be when Halil can actually define those sperm with the best DNA quality by looking at them with the help, probably, of some AI-driven device. So we're at the crossroads. We're now being able to identify who is at risk, where the serious problem may lie, but we can't do it yet just by looking at it. We're looking at a smartly dressed person who may actually be not as intelligent or as competent as the outer dressings may be, or the other way around. But I think with your help and AI's help and better optics, this and 3D analysis to look to see how the tail really moves, I suspect we're not that far away from that.
Yeah. I mean, there's certainly advancement that is going on there. 10 years ago, we've been discussing DNA fragmentation. Should we do it or should we not do it? Today, we're discussing how to do it in a standard way by using flow cytometry and other technologies as well, and also which method of choice should we do it. So it's not a question of should we do it or not to do it, but how we do it at the moment.
Yeah, how best to do it.
Exactly.
Yeah.
Exactly.
Because if you stand back from this, the health of an embryo, and indeed the health of the child, depends upon the woman's DNA and the man's DNA. This is a fundamental concept, and there's no escaping it. So I think that the DNA quality of sperm, just like the DNA quality of our other organs, is of fundamental importance to our objectives.
Thank you. So in terms of people like myself who have azoospermia, who might want to explore a microcesarean, it's not an enjoyable operation, right? It's having your testicles cut open, where they go looking for sperm directly. But in those circumstances, Jonathan, how can AI-assisted technology help a microcesarean operation?
Okay, so AI, of course, can do a lot of things. It can look at huge data sets, and it can tell us whether various features of that man's history, when put together in an algorithm, a sort of predictive sum, whether AI can say this man, who apparently has no sperm, might be more likely to have sperm in his testicles than this other man. So AI may help us choose which person might be more favorable and therefore might have a need or have a lesser operation. Now, before we get to that, what Halil was talking about, which is the speed with which an ordinary sperm specimen can be assessed, will be helped by AI. So is it really the case that this specimen has nothing in it. Or if a human was prepared to look for 6 hours and a robot for 1 hour, would we actually find 1 or 2 or 3 sperm, which we could build on, possibly by altering the hormone levels, some kind of encouragement treatment. And so AI might actually tell us that several of these men who we thought had nothing actually have something, and that this man, as opposed to that man, is more likely to succeed with the microTZ and may only then need a smaller, shorter operation. So we want to get away from, people like me want to get away from a really unsatisfactory situation, a bit less unsatisfactory than unexplained infertility, but coming to a man and saying, well, you might have some sperm in the testicles, it's 50-50. Now, crikey, if you apply that to any other surgical procedure, you've run a mile from a surgeon who told you it was 50-50. Say, crikey, hip replacement, 50-50. So I'm not, no, let's go somewhere else. So we've got to do better, and AI may help us through algorithms, and possibly even through better imaging and techniques, spectroscopy techniques that might just show us little pieces of the testicle that might be more likely to have sperm than not. So the answer was a long way of saying yes.
It's a good answer. So Halil, you recently helped make history with something called ICSI Spy.
Yeah.
Can you tell us a bit about that, please?
Yeah. It was one of those conditions where semen analysis has 100% diagnostic value, basically. So the case was a global zoospermia case. Was a patient that Jonathan and us actually took it under our care, basically, together as avenues of Jonathan. So the patient has complete global zoospermia. So that means that the sperm is going to miss a cap on its head that is responsible for activating the egg following fertilization. So if you think about the egg as a gun that is loaded, the trigger is going to come from the sperm to say that, okay, let's go fertilize. So these sperms, lacking that machinery on the head, on the cap, is going to be lacking the trigger mechanism that is going to say, go fertilize. So the patient had 2 previous failures and was suggested to go for sperm donation. But having experience before about globosospermia, so we wanted to try something else. We know that given that these eggs receive a certain signaling mechanism, which is controlled by calcium signaling actually, can fertilize normally and receive these globosospermic sperm into the egg and then fertilize normally. So we spoke with the patient for lengthy durations, and then we came to the conclusion of let's give it a try with this alternative ways of activating the eggs. So we made a plan of having a modified ICSI. It is actually a more aggressive way of doing ICSI in a controlled manner, so that we can trigger that activating mechanisms and push calcium more into the egg and say that, okay, let's go fertilize. And on top of that, with coupling some chemical activation methods as well. So we use something called calcium ionophore, which is basically a chelating agent that transfers calcium ions from the outside environment to the inside environment. But we tweaked the protocol a little bit and made it little bit more aggressive, not on the too aggressive side. We don't want to cook the eggs. So we used the double activating protocol on top of the modified ICSI. And then we left them to culture to see what happens next day, if they fertilize or not. So total of 9 eggs were injected in that case, and we saw fertilization in 6 of them. So previously, the patient had 2 failed cycles without any fertilization, and one of them involved calcium nanopore as well. So having 6 fertilization, of course, brought a lot of joy to the couple's life, let's say. But of course, we waited more to see if these embryos are going to be viable or not. So we extended the culture to day 5 and 6, and we saw that we have 3 blastocysts, 3 viable blastocysts out of these 6 fertilizations. So we did a biopsy of those ones and see that 2 of those embryos were actually euploid, having correct set of chromosomes that are fit for transfer. So we were, of course, celebrating, jumping around, hugging around and everything, as you can imagine. So we did 1 transfer. It was a failed one with the first try, but on the second try, we achieved an ongoing pregnancy. And I believe the patient is approaching past 20 weeks, almost 30 weeks now. It's coming to the term of the pregnancy slowly, let's say. So that was the name that was given to that form of human treatment.
It's great, and it's great to hear of your passion and joy for when this happens.
Of course,
and you make this development.
It just makes our day.
Yeah, it's brilliant. And, like, Ryan, from a current patient's perspective, how does it make you feel and to know that all this development is happening with science?
Yeah, it's incredible. So just to give you context to where we're at, so my partner had the egg retrieval surgery not too long ago. And then I can't keep up the terminology exactly, but the blastocyst.
Yeah.
So I think we had 9 originally, which was down to 2, and we had 1 successful
Blastocyst. Yeah.
And so that whole ICSI procedure was obviously completely new to me. I can't quite fathom how you can. It's almost like a tweezer, isn't it? You sort of pick out the strongest.
Yeah, exactly.
That's how they described it to me. Maybe you've done both version. But yeah, it's incredible to see what you guys can do. And it really goes a long way to families like mine, because it gives you a real strong sense of hope, knowing that there's tech, but also very skilled people like yourselves who can operate it and take what is not the most ideal situation and make it work.
Right. Yeah. I mean, if you think about it, as science, let's say, not as individuals, as scientists, as clinicians. So we've been practicing with ICSI since 1992.
Okay.
So there's a huge knowledge accumulation that has come to this point.
Okay.
So that's actually how, by accumulating all that knowledge and trying to put something on top of it, we are trying to overcome these obstacles.
Yeah.
These obstacles, like 10 years ago, would be deemed impossible.
Yeah.
But now, by as I say, by finding some creative ways, some out of the box thinking, we can find alternative ways of doing things rather than just say, okay, let's go straight to sperm donation, which can be,
that's
daunting.
Yeah.
To some people. It's okay. It's okay, but I think that is the easy way. We should try and push the boundaries further a bit.
Yeah.
Before going to that stage. So
thank you.
So yeah, I think that's a very important point, because throughout my professional life, observing what has happened since ICSI was not invented, but was stumbled upon.
Yeah.
It was discovered by mistake.
Yeah.
But ever since that time, we, the doctors, not so much the scientists, but the doctors have been asking the wrong question. The question we've always been asking is, how can we make this next cycle better? Because we want to do another cycle. The question we've not been asking ourselves is, why did it go wrong the last time? How can we overcome and understand what went wrong? So Halil's example of understanding why these sperm that are globular in shape didn't work, and using the information from the last cycles without fertilization, but with the calcium punch and a bit of current he was able to modify the next approach, but only by actually understanding what had gone wrong. Now, one of the reasons we've not been able to think out of the box is because actually across the world, we've just gone on doing the same thing.
Yeah.
We've had one tool in the box, IVF, and one problem, no baby, a nail, and we've just gone on banging the nail.
Yeah.
But a different approach is going to be more time consuming, much more satisfying for the scientists, but it requires a lot of effort and thought. And my lot, I speak for the doctors, perhaps we've not been quite so good at either of those functions. That is effort and thought. We're good at doing things, but you've got to go a little bit further.
That's amazing, thank you. And so I think to round off that point, to use the word you used, Ryan, hope, because that's often all we have left, and you're clinging onto it like a finger hold. And that's what yourselves, your peers, your colleagues in this clinic, in the country, in the world are doing, and giving patients. So thank you, thanks for what you continue to do to push those boundaries. Lifestyle, huge topic, I know, and one that, Ryan, you mentioned at the outset that you lived what you thought was an optimal lifestyle.
Yeah.
So Jonathan, what is it that we could and should be doing to help our sperm health, and what could be potentially harmful and hurtful to that as well?
Well, I think in a nutshell, all the things that we know are bad for our health will be bad for sperm production and sperm quality. So if you think about nicotine, smoking, then we know that throughout our bodies there is a higher incidence of cancer. It's not just the lung, it's all over the place. And that, of course, is because of the damage that the smoke and all its constituents does to our DNA. So if it's messing up the DNA in your lungs, it's going to be messing up the DNA in your sperm. As we put on weight, so smoking is right up there. Anabolic steroids, which not that many people use, is probably number 2, because that will switch off sperm production because it alters the hormones. And then we come down to all the other straightforward health issues: obesity, too much sugar, too much alcohol, and all of that as a package increases the tendency to inflammation. And once again, particularly the obesity, will reduce the testosterone levels, because the testosterone is metabolized by that extra abdominal fat. So if you think about a lifestyle that is going to give you more longevity, which is going to decrease your BMI, which is not going to add toxins and poisons, then you will be doing good things for your sperm and your sperm production. The difficult area, which is almost impossible to prove, but the data is developing, is about the various plasticizers and other preservatives and chemicals in processed foods, and in the way we prepare those foods in plastic utensils. Now, the problem with this is that we're verging, because it's difficult to get evidence, we're verging, if we're not careful as doctors, into snake oil territory. But if you look at the constituents, particularly of over-the-counter foodstuffs and preservative foods, then you will find a huge amount of plastic, of pesticide, of fluorinated hydrocarbons, of bad stuff. And if you give that bad stuff to animals, it makes them infertile. I think if we eat all that bad stuff for 50, 60, 70 years, we begin to alter our epigenetics, and therefore we may be passing on problems to the next generation. So again, a very long answer. Yes, very important.
And Ryan, from your perspective, someone really took time, attention and care with your lifestyle.
Yeah.
How did that make you feel when you were told that there were some issues with your sperm quality?
Yeah, it's probably useful to give some context. So I have obviously a son, Leo, who's incredibly healthy and clearly didn't really have too many issues conceiving Leo. But after a year of being primary caregiver to my partner who was unwell and sort of a solo parent, I put myself under a lot of pressure. And I suppose all the sort of manly physiological systems that we just become used to, I could just feel them sort of switching off. So I was super lethargic. I wasn't recovering from training very well, or at least very slow. I had a very low mood, no libido, and just generally felt a fraction of myself. As a result, I went to a sort of male health clinic, if you like, had some blood work, which revealed that my testosterone had almost bottomed out. So since then, almost 3.5 years ago, I've been taking TRT. Which I don't know, maybe you'll be able to tell us more, but I've sort of led to believe that that is the sort of primary reason as to why I'm in a bit of bother now with my sperm quality, and morphology and motility. So I think the first sort of course of action that I had to take was to reduce the testosterone up the HCG and almost sort of re-engage and reinstate the sort of natural bodily functions from the testes. So I don't know if in my case the lifestyle factors were as of great importance as the fact that I was on TRT. Does that understand?
Yeah, absolutely.
Yeah. Maybe I don't. Do you have some?
No, I recognise that entirely.
Yeah.
So if, for whatever reason, a man has a low testosterone, then of course it's quite difficult to keep fit because the muscle bulk goes, you feel lethargic, right? The libido goes down, therefore the mechanics of ejaculation and the systems aren't working. And so we get into a vicious downhill spiral because we can't exercise, put on the weight, testosterone even lower. So if you start off for whatever reason with a low testosterone, all of those, this will enhance those lifestyle issues. But of course, what Ryan is describing is not being given testosterone first off to improve the sperm, but being given something to make you make more testosterone, the HCG, which is a way of improving the hormone levels without damaging the sperm.
Maybe somewhere along the way, it's quite hard. I find it quite hard to stick to because I take it sort of 3 times a week, and I inject into my belly. It sounds like a simple sort of procedure to stick to, but I'm pretty awful at it. So if I skip and I'm sort of out of my required dosages, I wonder if that's had like a sort of compound effect over time. But that's just me. I mean,
Yeah, no.
You said that you take.
Yes, so I'm also on TRT, most likely as a result of, so my levels bottomed out after I had the micro-TZ, which is one of the potential outcomes from it. My levels were always on the low end of normal anyway, as a result of my primary hypergonadism, and it's utterly miserable having low testosterone. It's been said that for a man, it's the tide that lifts all boats in the harbour. We are dependent on it. It's our primary hormone, and yeah. So as a result of that, I'm now on TRT. I mean, my ship has sailed. I had no sperm anyway, so that was less of a concern for me. I take an injection every 12 weeks. That's quite literally a pain in the ass. Not enjoyable. I always kind of kick that can down the road and worry about it when it happens, but then I get about sometimes up to a week of aching after it.
Oh, really?
Yeah. But I can feel when I'm coming towards the end of my cycle, you feel that drop in energy, just general mood and just the zest for life goes.
Yeah.
And it is but I think what's really, really important here is that, like you mentioned, you went to a proper clinic and were assessed after blood work.
Yeah.
If anyone is feeling these symptoms, please go and get proper testing and seek your TRT from a clinically approved and a medical medically trained person, because there are some nefarious actors out there, and heard of the results that it can cause, you know, and that's under supervision of it as well. I'm sure you can attest that you probably have people in clinic who have been sourcing it elsewhere and then are seeing the impacts of it when they come to.
Yeah, I take responsibility on behalf of the medical profession from this. Firstly, we've not all got our minds round as doctors the awfulness of not having enough testosterone, actually, as a group. And then we sort of make it difficult. The poor old National Health Service says, well, general practitioners, you know, aren't up to doing this. You've got to see an endocrinologist in the hospital. Well, for heaven's sake, really? I mean, you know, a doctor's a doctor. This isn't that difficult. But we constantly put barriers in the way, which makes the patients feel awkward in the National Health Service, as if they're asking for something that they don't deserve or is in some way too expensive. This is nonsense, really, because the benefit, as you two will attest, of having a normal testosterone compared with an abnormal testosterone is enormous. And if it's a pain in the bum once a month and actually not really that expensive in the scale of things, and you can function and you know, properly, and for heaven's sake, let's put it in context, as a member of society, pay a bit of tax as opposed to lying in bed and not being able to do anything, then we ought to get real as doctors and just start recognizing it and just doing it. But I entirely agree, be very careful how you source it. And my job is to get out there, once again, get all the doctors around and say, let's just do this. And not get too bogged down with the nice guidelines. If it's a guideline, it's likely to be out of date.
Thank you. So yeah, that rounds off everything for the topics, but certainly got time for questions. Are there any in the room?
Is there a loss of testosterone common for that procedure?
Is what, sorry?
The loss of testosterone post that procedure?
I certainly remember it being written down as one of the risks, but sure Jonathan can.
Well, like so many things, it depends where you start. So what the level is. But as I was saying, if we can try to choose those who are more likely to have sperm and to find a way of knowing even which side, which testicle the sperm may be, then we can minimize the risk to having a low testosterone afterwards. So it needs care, and then it needs a really good, that's a silly word to use, helpful, that's a silly word, skilled embryologist, because you want to know as the surgeon whether that first or second or tiny little tubule you've taken out has got sperm. So it requires careful assessment. Otherwise, quite literally, you will remove too much tissue. You may operate on both testicles when only one is necessary. So this is a really qualitative thing. There's a huge difference in outcome from doing this when everything is aligned, the right equipment, the right people, plenty of time to do it, the right team in the embryology lab. Now, if you've got all of that aligned, then the number of times that you will seriously damage a testicle will be less than 10, 8, 7%. Yeah. Although it still depends where you start. If you start very low, well, it can only get worse.
Thank you. And there's another question at the back there.
Thank you. Jonathan, you touched on the toxins and poisons and processed foods. But I guess in modern world, it's pretty difficult to avoid all of that, isn't it? So I just wondered if there's any pragmatic advice on how you navigate the food lab, avoiding processed foods.
Okay, so the question was about the dreaded toxins in the processed foods. So I think the first thing is that green vegetables, fresh, preferably not wrapped in cling film and preferably not full of pesticides, will always be good because they're antioxidant. The processed food, frankly, there could be anything in there, and there's an awful lot of stuff. So one's got to think about this, firstly, the source, and secondly, its packaging, and thirdly, how it was processed. So we don't want too much sugar, we don't want too much trans fat. So we're sort of cooking from scratch, and we're keeping plastics out of the frame. Now I've got a bit of a thing about this, as you can probably tell, and I suspect that many of my colleagues wouldn't really agree with this. But we've got to think to ourselves out of the box. Why have sperm counts declined by 50% in 50 years? This didn't just sort of happen by miracle or act of God. And it's a bit quick for a genetic and even an epigenetic effect. But there will be epigenetics in this. And what are epigenetics? They're things that stop the messages getting off the gene. And so this has got to be the environment. Now, some of those plastics are coming from the atmosphere. Even the wonderful electric cars, they charge their batteries by braking. And the rubber comes off the tires and we breathe it. So it's not all foodstuffs. It's water as well. Reports from the BBC of only yesterday, chemicals in the drinking water. Yet another fine. Now, it's quite difficult to expunge all of this because it's all around us. The phthalates are in these chairs, fire retardants. So one mustn't get too anxious about it, but I'm sure it's there. So I don't want to turn people into obsessional, crazed lunatics in the supermarket sort of throwing all the stuff out. But there's something in this.
I'd like to give an example of this one as well. So I completely agree with everything Jonathan said. So there's a report, actually. It's one of those textbook examples that we give to students, to colleagues, to conferences and everything. So there was a compound that was used in a factory. I forgot the name of the compound, but I will find it out. So it was found that factory workers in the factory was actually having lower and lower sperm counts and having difficulties reproducing. So scientists was investigating that and found that one of the substances that were used in there was actually causing this. So it took about 45, 50 years to actually ban that substance from use. There you go. So it's one of those scenarios, those things. So we scientists, come up with things, but after this, it's the politics who's going to, to make it into policy making to, prevent that substance even reaching to individuals. So it's all interconnected, I believe.
Thank you. Are there any other questions in the room?
Question for Halil and Jonathan about your thoughts on PTT testing and kind of where that's up to. I think you mentioned it a little bit earlier in one of the processes, and I feel like you get lots of different information from that.
Oh, yeah.
So maybe it's hard to take a claim in one place, but I was just wondering.
Yeah, the discussion about PGTA has been going on for decades, actually. Yeah. So with the technology now that we have, we are actually capable of seeing as clinicians, well, our job is to maximize those percentages. And any tool that we have in our arsenal, in our toolboxes, which is going to bring extra little percentages to that, it's much more welcome in my eyes. So I wouldn't say yes completely, but I can say that we're going to be working much more efficiently. to utilizing those little chances.
But that involves, we come back to diagnosis, because there will be cases where we don't have a tool in the box, where we have to say, we can't add that 5% to the 1%. And we've got to be honest with that. But if we're not in the business of diagnosis, then we can't be in the business of prognosis and telling people honestly where we believe they are, despite throwing everything at it. And of course, we're human beings, we're bad at that. I admit I'm bad at that. You know, there's always something else you can try to do. And one's just got to be so careful not to give the false hope. So, you know, the clinging on by the fingernails.
Yeah.
We're not good at that. I'm not good at that.
Any others from the room? Any questions coming online?
I knew I'd talked too much. They've all gone away.
Yeah. Oh, wow. Thanks for that, Will. Can we have treatment if a partner has had epididymovastomy? Anyone else?
No, you
Some
did.
crazy.
You did that beautifully. It's an epididymovastomy.
That's the one. That was right on the tip of
And
my
what?
tongue.
And what was the rest of the question?
Can we have treatment if their partner has that? Please.
Well, that thing is designed to get the sperm to come back into the ejaculate because it has bypassed an obstruction. It's got the bit of the word ostomy, which means a hole. So somebody, a surgeon, has joined a vas tube to the little bit on the side of the testicle to bypass an obstruction. So the answer to the question is, if it has worked and there's sperm in the ejaculate, then this may be the sort of case for ICSI. And if it hasn't worked, well, then there may still be sperm in the testicle. So there may be a role for the dreaded sperm retrieval.
Thank you. Another question says, thank you so much for the insightful presentation. I'm curious about advances in imaging, particularly another one, holotomography.
Oh, yeah.
Nailed it. And how close are we being able to capture real-time metabolic activity or functional insights within sperm cells?
Yeah.
Crikey, that's
a me
a
one.
setup for you.
Yeah, that's a me one. Yeah. So it's probably coming from someone who watched our latest video on the social media, actually. So holotomography. So it's one of those, advancements in optics, basically. So where we can actually look at any living cell or any cell that we put under a microscope inside that device to capture that in 3D and also in stunning resolutions, basically. Something like you don't see inside the lab. So that device is something on a different level. So on top of that, it has smart ways of analyzing the small organelles that is actually inside the cell that we don't have a way of analyzing inside the lab, inside the IVF lab per se. So with that technology that is coming into advancement, we are thinking of, finding creative ways of integrating that into an actual clinical lab, into an actual IVF lab. So in ways of, digital analysis and also optical analysis that has been done really well in other cells and tissues, we're trying to replicate those ones in reproductive cells and tissues. So we are coming to experimenting with cells, eggs, and embryos to find a way if tomography can once produce outcomes or giving us answers so that we can advance what we do inside the lab, or if we can put that device inside the lab and look at the cells and trying to find the best ones of the cohort for injection or for transfer. So these are the two ways that we are actually hoping that in the future we might be seeing more.
Brilliant. Thank you. What are the first steps after a diagnosis of azoospermia? One for you, Jonathan.
Well, the very first step is to be sympathetic. Just let it settle a bit. And then, of course, to explain whether this is about a failure of production or a failure for the sperm to get into the ejaculate. And then to, I think, right at the beginning, make it clear as the doctor, whoever the doctor is, of course, it should be a primary care physician because I should have educated them enough to be able to do this. But the most important thing to do is to prevent the man from having to go to Google and saying, right, this is a difficult place for you to be in. I accept and understand that. And we are going to look after both of you until we get resolution, whatever that might be. Practically, it involves some blood tests, some chromosome tests, which are sort of headline. They don't give us the whole picture, but they might give us an explanation. An ultrasound scan is very important to make absolutely sure that there's no serious abnormality in the testicles. One must look at the man's hormones, just as Ryan was talking about, because there may be a low testosterone. And then one has got to think, are there any advanced techniques that might give us more information about whether, as I was saying before, this particular man has sperm or not? Can we make it better than 50-50? And something that Halil and I are looking at is the cell-free DNA in the ejaculate, which might just give us a little steer as to whether this is a more likely case for a positive sperm retrieval or not. But the message is look after him.
I think probably quite a quick fire question for you, Jonathan. Are there any side effects of using clomiphene long term for low testosterone?
That is a great question. Those who make testosterone would say no, because of course they want to give you a pain in the bum every 3 months. Yeah. Clomiphene, different forms of clomiphene have been tested quite long term, and it is probably safe for that purpose, probably, but it is absolutely unlicensed, and therefore within the National Health Service, nobody will prescribe it for that purpose to a man. So you've got to be a little bit careful. There are a few side effects of clomid. They are rare, but they exist. And what it really boils down to is whether that person who wants to take it long term can find a physician or a doctor who's prepared to prescribe it long term, because the rebound, if anything goes wrong, comes on us. So, I can understand people are a little bit reluctant.
And on the topic of testosterone, can a varicocele cause low testosterone at all? And also, are there any natural ways to increase testosterone without medication?
So the answer to the first question is a straightforward yes. And the bigger the varicocele, probably the more effective they have. It's one of the reasons to treat varicoceles in younger men, to preserve their testosterone for longer. This is new stuff. the NICE guidelines have only just got their mind around treating varicoceles at all. So if anybody went to their GP and said, I've got a great idea, I want you to treat my varicocele, refer me because I've got a low testosterone, that's not going to gain traction. But the answer is still yes. Natural testosterone increase, certainly exercise, without a doubt, the weight loss we've discussed. And then there are, well-tried and tested ways tangentially of raising it, making sure that the vitamin D levels are all right, zinc levels, that's where the oysters come in as an aphrodisiac. And interestingly, some people have looked at the skins of pomegranates. So there's a little dusting of snake oil.
And staying on the topic of varicoceles, would you recommend treating a varicocele for a second time, which as the varicocele returned 18 months after, which has been confirmed via an ultrasound scan? Would you recommend secondary treatment of varicocele?
When it comes back to diagnosis, it's all about why it might have recurred, and is there an underlying vascular reason for it? So it's going to need some fairly sophisticated imaging, a scan with some contrast to see why it's recurred, and then why it's recurred, what is the best secondary procedure.
Thank you. And a follow-up to the question about my favourite words, the epididymostomy. Getting there. They actually had that with yourself. That's seen that this new AI is available or becoming available. Wondering how much time that they should give to heal before thinking, because it hasn't worked, before moving to other avenues of sperm retrieval.
I think they should send my secretary an email, and I should speak to them on the phone.
Yeah.
Because you can't talk about individual cases in front of an audience.
Okay, I think that's it. Yeah, thank you very much. We have time for pre-submitted. Yes, yeah. No, we have some pre-submitted questions as well. Some of them have been covered throughout the evening. So how long after a varicocele has been repaired do you need to wait to try again for IVF?
So out there, the word on the street is 3 months, 70-something days for new spermatogenesis. But actually, the best results are longer than that, 4, 5, 6 months. Often these interventions, it's better to wait for 2 sperm cycles, but everybody tends to rush at it, of course, because it's in the nature of wanting a baby.
Okay, thank you. Can someone with azoospermia still be a father?
Yes.
By clinical ways, or like myself as a sperm donation, as a donor recipient father?
So if you look at all men with non-obstructive azoospermia, then as it stands, about 50% of them will have sperm. And depending upon the weight of the partner, probably 20–25% will father children, depending very much on the age of the. So first we got to get the sperm, then we got to use the sperm by all the techniques that Halil is describing, and we also need a good egg. So people confuse success with finding sperm. You've got to find them, you've got to process them, you've got to look after them, and then you need a good egg. So, but the answer is yes.
Thank you. What treatment options are there for someone with erectile dysfunction?
How long have we got? So this is a huge. What treatment options? There are many. There are drugs that increase testicular penile blood flow. There are embrocations, potions, which increase blood flow when applied to the skin. There are devices that help the musculature of the pelvic floor, or generally a sexual function. And then we get into the whole business when none of this works. We get into the whole business of surgery, which is a very long, painful, but sometimes successful story.
Thank you. Is IUI treatment still an option for someone with 0% morphology?
Yeah, technically speaking, yes. The reports say that the chances might be lower. But yes, as long as there's sperm, the tubes are open. Again, we go back to diagnosis again. So it takes two to tango, as you say. So if the tubes are open, the sperm number is good, and it hasn't been tried before, the female age is suitable, let's say. Yeah, it can produce cancers, but if any of them is not, the chances are going to diminish as we do.
Thank you. And I think that kind of covers off the next question, but staying on topic of IUI, is it an option for patients with male factor? And that's kind of all we know about the male factor.
Yeah. I mean, when the male factor is involved, we like to, go further into different options rather than IUI. But of course, it's going to depend on the nature of male factor again.
Sure. Thank you. I think this one was covered in the talk, but just to confirm, can AI be used for sperm selection, especially in the context of identifying sperm with high or low DNA fragmentation?
So that one is of course, this is something that we are investigating as well. At the moment, we're utilizing motility and morphology, which we know can be translated hypothetically into DNA damages. So, but there are other ways of doing that, which we will be investigating more in the future.
Sure, thank you. And can AI be used to determine the reason for a lack of fertilization or arrest of embryos at various stages of development to give an insight for future rounds of IVF?
Use AI to come up with explanations for it.
Yes.
Not per se. No. This is going to be a human job.
Okay. I think they're a bit covered. My last 4 ICSI cycles failed. What should I do now for my new ICSI?
Yeah. The definition of failed needs to be clarified here. Is it the fertilization failure? Then we can do the spark thingy that we discussed. Is it plastulation failure? Then we can look at ways of selecting other ways of sperm, which we know that post-day 3 is going to be more important as the paternal genome kicks in as well in terms of embryonic regulations. So yes, that's going to be a long one, maybe a panel on its own to discuss that basically, but that's going to depend on the definition of failure a lot.
Sure.
Somebody better go out and get us some breakfast.
Yeah.
Yeah. And actually looking through the other questions, I know we have covered those. So I think that rounds everything off for tonight, unless there are any final questions in the room. There we go.
Ryan, what do you think we can do to help men have more of a conversation as they're going through the experience?
That's a great
actively?
That's a great thing.
Oh my gosh.
I'm sure I'm curious what input into it.
I suppose, speaking from my own experience, I suppose, I think there's, and this is not aimed at you directly, by the way, this is a generalized sort of answer. I think men just need to know that they are involved in the process, that actually they have full permission to ask questions, or I think men sort of sit on a lot of questions and they contain a lot of feelings and emotions because we're expected to be this harbour wall that will just get smashed into and we'll never crumble, we'll just take the hits. I think it's, I think as society, we just need to perhaps allow men, create a bit more space in the conversation for men, hold a bit more time in those conversations. And actually, I think when you do that, a lot of men really do sort of step to the forefront and they can be a different type of support than their partners or friends or families even realised. And it took me to, almost lose my partner twice to birth and delivery complications. To sort of really take a sort of 180 spin on how I communicated my emotions and feelings and how willing I was going to be around conversations like this. And actually what I've learned is that the more vulnerable someone is, people naturally draw closer. And from my experience, I met Shaun 2 minutes before this. It took less than 2 minutes to realise that he was one of these kind of special blokes that is very vulnerable and open with his truth. And I think there's a lot of men like that. They just need to be given the chance to let that unfold. Does that make any sense? Yeah.
And I think for men to know they're not alone, and there are others going through exactly the same.
Right. Yeah.
And I see it time and time again. Firstly, this stereotype that men don't talk is just nonsense. It is absolute nonsense. I see it in our community. I see it at the in-person support groups we run. Men given the space, like you said, where people are being vulnerable and honest and open, just creates that environment for them to open up. And so, a lot of times it is like a pressure cooker. And giving men that place to release that tension, release that stress is vital for everyone, for clinicians, or partners who are the ones often carrying the burden because the blokes aren't talking. It just gives them that space to do it and know they're not alone, and everything they're thinking and feeling is not completely normal in a very unnormal circumstance. I think that's a really great way to round off tonight, because obviously the conversation was all around men, and we've shown it. We are part of the conversation, and we're here, and 50% of it. So hopefully this is the start of many future events like this. Thank all of our speakers, Ryan, Jonathan, Halil, and thanks for coming everyone tonight.
So if you would like to have a tour of the clinic, you can ask one of my colleagues where in the line, or if you would like to take the offer, you can scan my QR code here, or if you would like to come over straight away,
It's something
you
that
can ask the receptionist. Okay?
needs to be.
Thank you for coming.
It's turning out to be a taboo, isn't it?
Yeah, I'm doing,
It's
almost
amazing.
5 years now of sharing and doing my bit. I don't think it's going anywhere.